at this time. It's telling me my meeting is being recorded, which I'm delighted. Okay, next. So I think probably the easiest way to speak about how and why policy shifted is that we have a problem. As you can see here, the total number of drug-involved overdose deaths from 1999 to 2019, and I've added the provisional 12-month data for mid-19 to mid-20, which is the last available. And obviously, things are going badly. And in general, in any given year of the last 10, 65 to 70% of those deaths involve opioids. The majority of them now, vast majority now, heroin and fentanyl, but always still some that involve the types of opioids that could have been prescribed, whether they are from illicit market or from the doctor's office. Those are always part of it. And you can see some highlights that our own prescribing actually peaked in 2012, 11, the CDC guideline in 16. The arrow is slightly off, I think, because I moved the graphic. So early on, as this problem was developing, people noticed these parallel curves. Green line, opioid sales, blue line, opioid deaths. And so it seemed only reasonable, and I think quite reasonable, to say this excess prescribing or this run-up in prescribing is contributing to this problem of these deaths that involve opioid deaths prescription. And then we can talk to some degree about those that are involving heroin and substitutes. And certainly the public narrative is focused on the pills. There's a headline from the Washington Post looking at where the pills went from 2019. And we had a sort of big crisis response. This is kind of a summary of all of that response. In one slide, I show the HHS strategy, the president's commission, including, I think it's still Massachusetts current governor, Charlie Baker, and the picture in the upper right. But basically our overall crisis response across many congressional and state actions is to reduce prescriptions, to get naloxone into circulation, to promote medications for opioid use disorder to some degree, maybe not enough, but maybe we could do more, that kind of thing. Enforcement and profiling of prescribing, a big investment in research and model initiatives like Healing Communities, which has Massachusetts as one of its model sites led by Dr. Jeffrey Samet. The declines in prescribing have proceeded apace, and we're going to talk about these declines in a few different ways, but this is from IQVIA. It's a commercial outfit that summarizes all outpatient pharmacy data. They're summarizing morphine milligram equivalents per capita rather than number of prescriptions. Their projected figure for 2020 is sort of in the lighter blue, but then they project back with a green dotted line and say if where our projections for 2020 are correct, we're back roughly at where we were in 2001 in terms of milligrams total. If you use prescriptions per capita, maybe it's 2005 or 4. And then at the same time that this reduction happened, which was certainly a response to those parallel lines, this happened, which is that we started to begin to see mainstream media coverage and social media treatment of tragedies after physicians began to stop, reduce, taper, et cetera. The case on the left, a tapering event that resulted in suicide. Among the most commented, I think there were 5,000 or 10,000 comments on the Fox News article on this story. It's actually one where I've read the medical record. I've been acquainted with the spouse who lost her husband in this one. And on the right, a Washington Post coverage case from 2019. I even got to play a role in influencing how Centers for Medicare and Medicaid Services responded to this. In 2018, they proposed a change in the Medicare drug program, Medicare Part D, that would have actually created extremely stringent review criteria before any patient on prescription opioids could continue to receive a dose they might already be on above 90. So it's not just escalation, but if you're on 140 milligrams all the time, which is not that common, it would have been quite challenging for them to ever stay there. And we actually launched a letter to CMS with over 200 signatures, mostly from medical school faculty. It was covered on the front page of the Times. And I'll draw your attention to the paragraph at the bottom, which is my quote: "A lot of the opioid dose escalation between 2006 and 2011 was terribly ill-advised, but every week I'm trying to mitigate the trauma that results when patients are taken off opioids by clinicians who feel scared. There are superb doctors who taper as part of a consensual process that involves setting up a true care plan, but this isn't it." And in fact, CMS did change course and invited us to give grand rounds at CMS. They're actually very collaborative about this one. The CDC in 2019 announced that their 2016 guideline had been taken in too aggressive a direction. And I don't have a long slide on this, but the guideline that was issued urged great caution in dose escalation and even caution in starting opioids. But what it did not do was mandate that every person should have existing doses reduced to a fixed threshold. And it certainly didn't prohibit categorically any escalation of doses above 90. And as that was done, the CDC, partly due to pressure from people like us, decided to issue a guidance to say this isn't right. And the FDA, more or less at the same time, said, we're hearing about problems from people who are being stopped, including suicide. This is a concern. So you might feel a degree of whipsaw in terms of how policy has evolved. So where are we in terms of overdose deaths now? I did show you the same slide before, but I sort of want to draw attention to how the curve went down a little bit in 18. And I think people were beginning to think, okay, maybe the process that I laid out policy-wise is beginning to work. And then things kind of took off and got worse, partly because of a very poisoned drug supply that's illicit in nature involving fentanyl. And the best estimate, 81,000 deaths obviously is a concern. So given a failure or at least a policy reversal on face, there are now competing claims about what does that mean with regard to those prescriptions. And don't worry, we're going to get into the science, but I want to expose you to the policy claims first. So it's kind of a cacophony. So one party might say, look, prescription control drove heroin use and made everything worse. And then at the very same time, other groups are willing to say, no, prescription control was never about saving lives now, not in the short term. It was sort of a long-term thing. Of course, some people are going to have trouble now. That wasn't why we were trying to reduce the prescriptions. Another reversal of claims. It's no longer a prescription-driven epidemic. This is something the AMA wrote in a response to a CDC docket last summer. And then the immediate pushback is, it still is a prescription-driven epidemic. We prescribe more milligrams than, and you could just insert whatever country you wish. It could be Germany or England or Switzerland. So it still is. And then, final claim, what unleashed the crisis isn't what sustains it. And that's quoting me from 2016. So, but, amidst all these claims, and it can be tough to adjudicate, and I'm not sure that's going to be my purpose here. I really want to ask about the patient and us, because most of us who are on this talk are seeing people face to face. And I tried to expose this situation with a cartoon published in Substance Abuse Journal in 2017. And I commissioned this for an article at the request of the editor, said you should do a cartoon, which is the first time I ever did that for a medical journal. And the doctor is talking to the patient, says, and they're surrounded by things in the office, the CDC guideline, DEA, prescription drug monitoring. The doctor says, too many people are dying. The situation's out of control. I kind of thought they were helping you, but right now I have to stop your Lortab pills. And I put in the commercial name there. It's not normally what you do, but it's because it's a cartoon. And the patient said, but what did I do? And right outside the window, someone is injecting. There's a graveyard full of syringes. And you and I know that there is some relationship between what happened in offices and what happened outside the window. But for us as clinicians, we're inside the window when we're having these conversations. So why do I focus on prescribing policies, for this talk at least? Because 8 to 10 million Americans receive opioids long-term, and some additional number are going to need them. That's a lot of people whose healthcare is being changed. Because prescription policy changes were prioritized up front for aggressive action. Because they were the fastest thing to change. The other stuff was all slower. And because I'll submit to you, and hopefully you'll decide for yourself if you agree, we permitted changes to care that cut against normal standards of medical evidence and cut against our ethics as a profession. And no one is going to reclaim our principles as physicians for us. We'll have to reclaim them for ourselves. But we shouldn't deny a role for prescriptions in launching this crisis. I showed you parallel lines, but let's go there in a bit more detail. Because opioid addiction really can start with pills, and it can really start with pills that are received in a doctor's office. And I'm showing you the picture. It's from the public website of Ryan Hampton, who I deeply admire. He is a public recovery advocate. And his story is that he was a White House aide. I think it was the Clinton White House at age 19. In the early 2000s, he got on opioids for an ankle injury that was complicated. And he says, I didn't know what was going on. in my body. We actually have a pain psychologist attending this grand rounds, probably where that conversation would be great. And as he kind of escalated doses, he started getting multiple prescribers. The doctor realized and stopped the prescriptions, and he transitioned to heroin. And it escalated for a period of years. And then he eventually went into recovery, where he's been working on policy issues. But this really happens. And I think most of us have met at least some patients where this seems to be what happened. And of course, you can say, well, they had pre-existing depression. They had messed around with alcohol as a teenager. But those pills seem to be a key part of the story. Okay, so if it can start with pills, how often does it start with pills in the doctor's office? The data on this remains strangely perplexing, a little bit unclear. There's a tremendously good survey funded by NIH called the NESARC, where they survey a population sample of individuals for addiction diagnoses, as well as mental health diagnoses. And among those people who were identified as having heroin opioid use disorder in 2012-13, they asked, what did it start with? And among the whites, at that point, 50% said it started with pills. And among the blacks, 26%. And by the way, those 2012-13 numbers were at a peak and quite a bit higher than when they did the same survey 10 years earlier. Okay, so it started with pills, but where did the pills come from? And this is where it gets really hard to know what data to trust. This is a small study I'm showing you, but among opioid users, young adults 18 to 29 in New York City, 13% said, almost all started with pills before they used heroin, not all got to heroin, but almost 13% said they had a doctor's prescription for them before they engaged in non-medical use of those pills. And of course, that means 87% said they'd not gotten a doctor's prescription before they engaged in non-medical use. However, this is a local sample from New York City. I've seen one other local sample of this nature, but this is not often obtained. Well, what about prescription opioid use disorder? That's this equivalent survey from NIH hasn't asked, well, where did you get the pills first? It just didn't ask. How often do patients develop new onset addiction after long-term prescriptions from us? And the data that we have available, and I'm combining two papers here, suggests a range of 0.7 to 7%. And that range, the lower end is with lower dose. I would argue that the risk might be quite a bit higher in people who are ages 16 to 25 at the time that they receive those pills. And the types of study we have don't perfectly show that. But the director of the National Institute on Drug Abuse said it's surely less than 7. So in this situation, with some murky data about how often addiction begins from the pills we prescribe, but certainly our pills are out there, they were a focal point for policy even last year, despite the reduction in prescribing, which got us back to 2001 levels. And PR, emphasized that we're still just flooding the US, and they really focused on short-term prescriptions, many of which are not useful and not needed for conditions that don't need them. So you see this graph again. How did we make such aggressive reductions as a policy matter? How did that happen? So reductions in milligrams across the country depended very heavily on reducing, either stopping or reducing doses in those long-term recipients, the 8 to 10 million. Why is that? Well, as you might guess, the largest proportion of the milligrams are received by a small percentage of people. 75% of MME, morphine milligram equivalents, are received by that long-term recipient group. So if you're an insurance plan, just target that group and you can show a 30, 40, 50% reduction pretty quickly. What do we do to these patients, however, as clinicians, should be guided by evidence and ethics and not just the policy du jour. And what has happened is not what might have been advocated. I think what would have been advocated, and some groups still talk about, is a transition to cautious prescribing. And for those of you who are loath to start opioids, but try all alternative pain interventions first, you've made that transition in the new cases. But for those patients who are on these medicines already, cautious prescribing is not the step that happened in terms of what our national data show. Instead, we had something I'm terming incautious stoppage. So a paper published this year, but which maps to what I had seen previously, both anecdotally and in small papers, showed in Medicare data, abrupt discontinuation. This is published by Naprosh and Michael Barnett from Harvard. Long-term opioid recipients in Medicare Part D were looked at across the country. The discontinuation rate increased by a relative term of 49%, from 5.7 to 8.5% over about 5 years. That doesn't include the last 3 years. The proportion of those discontinuations that were abrupt was always high, but it rose between 2012 and 2017. So abrupt was defined as a final month prescription, meaning before you're off, that was greater than 50% of your prior daily dose. And that has become more common, not less so. Similarly, another Medicare paper published by Fenton in 2009 in JAMA Network Open, looking again at commercial Medicare Advantage opioid recipients, found the percentage tapered, meaning a dose reduction increased, and a significant percentage were tapered rapidly. So that's the sign that what's happened is not so much cautious, but with this group, incautious. Okay, I hope as you've processed this, you can get that I have a set of concerns and a bit of an agenda, but I think there should be a question exposed, and I want to say it aloud. I'm hoping you're wondering, wait, are you saying the problem is we're stopping a problematic drug wrongly? Or are you saying opioids are helpful in ways we're afraid to say aloud? And let me tell you the answer to that. Yes, it's both. So we have to detour for a moment. Before we talk further about opioid dose reduction, we have to talk about how good or how bad these medicines are based on available data. So I think I would set it up this way. If we had some other treatment or some other system of care for severe, complex, chronic pain that routinely worked for persons with severe long-term pain, opioids wouldn't be considered. There's too many downsides. I would say we make ethical trade-offs in our care decisions by choice. Opioids evidence in cancer or sickle cell disease is no stronger than in any other condition, and yet as an ethical matter, we have decided to grant leeway there. We could or we could not decide to make the same ethical choice in other forms of pain, whether it's from rheumatic disease, I pulled my back, whether it's from complex disorders that we barely understand, like complex regional pain syndrome. Randomized controlled trial summaries will govern my next 2 slides. I have a little bit of a warning about using RCTs to discuss overall effects of opioids. It's a little bit like an RCT of scalpels for their utility in surgery. Like, that's worth knowing, but at some level, the surgeon and the surgery and the situation could matter a lot. RCTs are valid because they blindly compare 2 groups and you get a valid comparison. But the cost is you don't know the context of recovery for that individual in any great detail. And so you kind of lose something. And if you're interested in that limitation of RCTs, I've included a reference from the addiction literature by Tucker and Roth, Addiction 2006. Okay, all RCTs summarized in a slide. This is from an AHRQ review that was led by Roger Chow and published by last year. They said opioids confer small benefits on average relative to placebo for pain or function, with data lasting out to 1 to 6 months. There was a lack of trials versus placebo greater than 6 months. There is a trial against another active treatment where the 2 things did about the same out to a year. And on average, opioids do not outperform non-opioids. There's a German set of reviews that came out just a little earlier, and they had a pretty stringent standard for benefit with osteoarthritis, a greater than 50% pain reduction. And they said no benefit. And then for low back pain, the standard was a little different, and they said yes benefit, 2 different papers. I've included potential conflicts of interest for both groups at the bottom of the slide. Okay, in long-term open label follow-up after those trials of opioids are completed, a lot of patients stop them. They just can't stand the drugs, so they get off of them in the first few months. But in post-trial follow-up data, which is also published in the European Journal of Pain, the majority who enter the extension phase report that their pain is still reduced and that they feel there's a diminution of a disability as a result of the opioids. We can argue about it if you like, but that's about 30% of the people, and those folks typically do not have endless dose escalation. So I would argue there's some group that seems to be benefiting. Okay, so what about the alternatives? So the RCTs were also reviewed by HRQ, and they're subject to the same kind of dilemma. You don't know the context, you don't know the rehabilitation needs, you don't know the family and community. But for the non-medication treatments, there were 233 randomized controlled trials. Often the N was less than 70, which is obviously not great. Effect sizes were small. And probably the most promising one was for low back pain. Psychological therapies seem to offer a small effect out to 1 year. For knee pain, I thought this is curious. Exercise was no better than anti-inflammatories. Most of the trials were less than 6 months. So I don't feel wildly enthusiastic about this lower risk set of treatments, even though they are lower risk. For non-opioid medications, 184 RCTs, very few good quality ones, however. Many medicines have short-term benefits. Long-term, no treatment had a large effect. So here's where we are at. My summary on thinking about the treatment decisions we make. Pain isn't just pain. It's always three things, three things together. Opioids have short-term benefit, sometimes long-term. The alternatives have less risk and mostly less evidence. Long-term opioid therapeutic dependence is a mixed proposition. In some individuals, they maintain function and improve disability. In others, and I'm sure you've seen this, they're ineffective and the person has dependence and disability. One starts opioids, not because they're a first or second line, but because you have a challenging dilemma, and of course, it's best to do with a plan. So that's the answer to the two-part question of whether we're discontinuing problematic medicine wrongly or whether there's a value to these medicines that we're afraid to mention. That's my take. I want to come back to the prescribing change policies and how they were carried out, and then we can move to the arguments for those actual changes in patients. So as I mentioned before, prescription declines began in 2011-12. We began to absorb a concern, a reality. It was in the literature. It was said up till 2016 that half of overdoses involved a prescription. I'm showing a graphic from the CDC, which is no longer on their website. The CDC guideline in 2016 was received with that in mind. People thought, okay, if half the overdoses involve our prescriptions, this is gonna fix things. And that focused on cautious use. It didn't mandate dose reduction, but the CDC didn't make the policy. Many parties make policy at once. This is a key thing to recognize in complex domains. So there are many, many entities that I call policy actors, divided into quadrants here. There's governmental agencies like the Congress and HHS and the Department of Justice, which can investigate us. There's guidances and matrices. I put the CDC and VA, but note National Committee on Quality Assurance. We're going to come back to them. On the lower right-hand side, I put payers and other entities, pharmacy chains and benefits managers. Some of these entities are being sued for the opioid crisis. They now have a liability for how they are seen as having managed matters in the first 15 years. So they're trying to contain those liabilities and reduce doses. And finally, the reality is most of us do not have time to read all the documents issued by all these agencies. So we're influenced by what I put in the upper right-hand corner, framing voices, journalists, book covers, what Vox.com or New York Times tells us gives us a sense of the flavor of the month. Those are our policy actors. Of course, I'd be remiss if I didn't ask, where are the patients in this? I mean, this is a policy that affects 8 to 10 million people. Those people have mostly not been at the table and describing how policy should evolve in their own care. That's a concern. As an example, two examples follow. One is a quality metric. Under the HEDIS system, which is sort of a broadly endorsed set of quality metrics for healthcare organizations, we have a metric, use of opioids at high dosage. As of 2020, they simply say, let's count the number of people on opioids at over 90 relative to the people on opioids at all. The higher the percentage, the worse your care. There's an exception clause for hospice, but not for other forms of complex medical illness. When that metric is operational, which it is, it pushes dose reduction. The only way to improve your performance at this moment in time is to take the doses down on the patients who have high doses, or to get them out of your practice and hopefully into somebody else's. So that's a natural effect or a consequence of a metric that's in place right now. It changes care. That's what metrics are designed to do. And it's enforced. This is not an optional metric. Payers use it variously to make payment decisions. Medicaid programs cite dose limitations partly due to the 2018 Support Act. Incentive payments from CMS, called the 5-Star program, use this metric. And if I read between the lines of a CMS report from its Office of Inspector General, they're actually using the same number to figure out who to investigate criminally. So that's a pretty powerful metric. This is an example of another kind of policy actor. These are US Department of Justice attorneys announcing to doctors not who they're prosecuting, but who they're warning. And at the time that they did this in 2018, this is in the Atlanta area, there were several other prosecutions, actual prosecutions that followed. They said it was part of an initiative by the US Department of Justice to reduce opioid prescriptions by a third. That was their goal, is to get the prescriptions down. So they're a policy actor. Could the threat of prison reduce our prescribing? I would submit to you, yes. We are not people who want to be in orange jumpsuits. Okay, so the message has been received. Doctors understand they should be concerned about this prescription. This is a slightly but it's from an actual clinic practice in Texas, photographed in money. On the wall, there's a sign at the door that says there's no narcotics here. Just to make sure you understand, there's a picture of a skull and crossbones. And then if you look at the bottom, there's a picture of the Grim Reaper looking down over a homeless person, actually presumably one of my patients, and the words drug addiction. So it's really a pretty stigmatizing message. But it's not that these doctors arrived at this message out of nothing. They arrived out of the situation we are in. At this point, we've sort of talked through opioids. We've talked through why they're problematic but might be used. We've mentioned the rapid policy shift. And my concern has been, what's the scientific data for the changes that we're making? Obviously, we haven't immediately reduced overdoses. But I want to draw attention to an overdose study from the VA because it's the first hint to me of why this is so concerning. This is an analysis published in 2019 of opioid overdose deaths overall, which is the kind of broad dotted line. They were going up. Presumably, most of those are going to be a rise due to heroin or illicits. The opioid overdose death rate involving natural and semi-synthetic opioids like hydrocodone or oxycodone is a dotted line that maybe very, very slightly is going down. Hard to tell. But what really drew my attention was the other line in this graph, which I'm going to show on the next slide. And it's the white line, and the axis for this is on the left. And it's the percentage of the overdoses where there was a prescription for an opioid in the 3 months before the individual died. And the way this reads to me is the overdoses went up. We didn't really change the overdoses that might be attributable to prescription opioids, but we didn't have contact with a prescription before the person died. And that's not, it's a little bit like saying the body is still there, but my fingerprints aren't on it. It doesn't feel good to me as an outcome of a major healthcare change. We want to show deaths going down. And as it turns out, this not having contact with patients is part of the outcomes, maybe not the intended outcome, but one of the repeatedly noted outcomes of the process we're in right now, where those patients who've been on this often have a termination of care after the prescription stopped. Clinicians are doing this for no reason. We'll talk about that. They're doing it because things get crazy. The patient uses cocaine, they lose the pills. Maybe they're just freaked out. It can be any of those things, and that has to be profiled still. But it doesn't, you lose contact with some of these patients. The most extreme concerning outcome in some instances is a suicide of a patient, which is what the FDA drew to a warning. And this one made ABC News in Utah. And the case is kind of striking. The family is depicted on the right at a younger age. It's the father in the family who died. He was a working guy. He was doing power line maintenance. I heard a whole podcast by this case. And ABC reports that insurance and dosage change were imposed. Adam had been on high doses before, but he no longer had those. And his daughter says, the night before he left us, he gave us all hugs and told us how much he loved us. They didn't know he was going to die at that moment. I'm glad he's not in pain anymore, even though we do miss him. And in fact, he did die by suicide. Now, we don't know, well, how fast was the taper? What were the other health conditions? What other kinds of care were offered? We don't know much about these cases because it's actually very hard to study unless families come forward and say, we're willing to collaborate with a research team to look at these in depth. FYI, in case you are aware of a family who has lost somebody to suicide, we have a public survey. We have suicide researchers and opioid researchers, and we're reaching out through social media, Reddit, Facebook, and people can do initially a survey by phone or online about what they think happened, even if they're not sure exactly what happened. And that will help us decide if there's enough reason to do a larger, longer study where you look at these deaths in depth, like the side of a plane crash or something like that. The outcomes for patients. Let's argue for taper and stoppage, first of all. I think I wanted that heading to say, what are the arguments for taper and against? So opioids were not proven superior to other treatments on average. So that's one argument that people would make and could reasonably make for reducing that treatment because they have a risk. And there are risks. And in the several papers, the risk of an overdose death, at least, is correlated with the prescribed dose. What I've shown in the right is a excerpt from a table published in JAMA in 2011 from Amy Bonnert's paper. It's looking at the deaths that happened in 2004 to 2008. And it does show, among many other risk factors for death, which I'm not showing you, that the dose was one of them. If we treat 1,000 people for a year with opioids in the way we did in 2004 to 2008, which meant there was a lot of co-prescribing of Klonopin and things like that, and the dose is over 100 milligrams, then 14.9 veterans would be expected to die out of that 1,000 over a year. And if the dose is low, 1 to 20, it would be 1.3 per 1,000. You could argue maybe we do a better job now. We scrutinize more carefully. We tend not to prescribe benzodiazepines, but it's that kind of dose response curve that leads people to want to reduce the dose. There also was evidence that there was a lack of comprehensive care resources that drove the prescribing, which means that we were prescribing in response to not having some of the things patients actually needed at the time. And there's a VA analysis published last year that shows having less mental health resources was associated both with having more patients at higher doses of opioids and with more rapid stoppage of opioids. And at one end of the spectrum, of course, and part of the reason people talk about taper is that the dependence can involve volatility of pain and emotion. Opioid use disorder, addiction is one end of that, but there are forms of dependence that can be not good, but which aren't fully qualifiable as an addiction diagnosis. And patients aren't always doing well. They're not doing well. So you want to change the treatment because the patient doesn't look like they're doing well. So our data in terms of trials of opioid taper are fairly limited. It's actually hard to recruit people for randomized controlled trials of opioid taper. So I'm showing two reviews. One is from Frank, published in Annals of Internal Medicine. The other from Mackey, published in JJAM. The Frank one had 40 studies, including 5 trials, not a large number of people. Most were short-term, voluntary, multimodal, high-touch services. And they said very low-quality evidence exists. They weren't saying there's not any evidence that opioid dose reduction may improve pain, function, and quality of life. And they weren't more than 1 or 2 where anything was worse. They said there was no data on mandates and few data on suicide or illicit drug use. Mackey also issued a kind of an update, which really didn't change matters much, except to say that the benefit of harms and benefits was sort of an unclear balance, maybe even a more conservative. Most overdose events, as it turns out, are at low dose. And I think that's probably worth thinking about if you want dose control to be your method of achieving safety. So there's 2 curves on this graph. One is red, one's gray. Red is the rate, the different doses received by veterans who died of opioid overdose. And the gray is case control study. So it's the people who didn't die, but were receiving opioids around the same time. And the red line is displaced rightward from the gray line. So there is some relationship between dose and risk of overdose. But most of those overdoses on the red line sit to the left of 90 milligrams, that is less than. So if the main problem is overdose that we want to prevent, but it isn't always driven by the prescription we write exactly as written, then we have to think about other things that are really driving a complex toxicological event in which an opioid figures, but which often alcohol, other substances are present. And VA data also provides kind of a nice illustration of that. In the Veterans Administration, we use a model to predict opioid risk. I'm not saying it's the best model, but it does use clinical data, which is kind of nice. And these are the odds ratios for an event that would involve either overdose or suicide across VA-wide data. And they actually pump up the numbers every single day so we can check risks on our patients, as precise as they are and as precise as they aren't. But there's a whole range of things that are associated with risk for these events. And it's the same predictors for both overdose and suicide, from co-prescribed benzodiazepines to the existence of concomitant medical illnesses, which are in blue, mental disorders and addictions in purple, and in the red lines, prior admission for inpatient mental health treatment and things like that. So all of these things are adding together to create the risk. And in comparison to dose, being at 120 morphine milligram equivalents, which I would say is a pretty high dose, increases risk in a veteran at least by about as much as having PTSD and being on a low dose. So this is a little bit like how we think about myocardial infarction risk when we're calculating whether or not to adjust the statins or start them. So now we need to talk about the data in the other direction. I showed you the most favorable data for taper that we have, but under real world conditions, things don't look quite as good. I'll just run through 6 studies fairly quickly. Retrospective chart review study, veterans, about 1,000. Stoppage of opioids was or action about 11.4%. Again, this is not proof of cause and effect, nervous, or there were behaviors of concern. This was retrospective. Dose variation in Kaiser Permanente data from Colorado, published in, I think it was JAMA Network Open, was associated with increased overdose risk, both upward and downward dose variation, although the small number that got to 0 had a lower overdose risk. There were 228 decedents in that study. 4 more real-world retrospective studies. Cessation from high-dose opioids at 120, which used to be the NCQA HEDIS standard, typically in Vermont was rapid and followed by a high need for emergency care. That was published a couple years ago. Cessation in a small clinic from Seattle was associated with a tripling of the risk of overdose death. These were 572 patients. It was published in Journal of General Internal Medicine. Of course, when they read the records, the doctors were responding to concerning behaviors in the patients, stopping the opioids, and then left with what turned out to be a higher risk situation. Not that everybody died, I'm not saying that, just that the risk was higher. Cessation associated with termination of outpatient care. I think I showed you that one. Then there was a case control study published out of Kaiser data. Again, this is not the most common outcome of stopping prescription opioids in a long-term pain patient, but statistically, there was a higher odds of new onset heroin use that hadn't been present before in the Kaiser Colorado data. Finally, partly because of concerns we'd observed, we spurred a VA study, which I'm a co-author on with Elizabeth Oliva, who runs those models I talked about earlier. And here we looked at and published last year veterans who had received any opioid analgesic in fiscal year 2013. So the data is a little bit old, which is a concern, of course. The outcome was death from overdose or suicide, and the model was done twice. But you got almost 3,000 deaths to work with. And the independent variables in this model were whether or not the opioid was stopped in the next fiscal year. And there was an interaction term to see if stopping after a long-term receipt or short-term receipt mattered, if they played a different role. And this included all of those risk factors that I mentioned before: medical, mental, other medications, et cetera. And the basic finding was that suicide deaths were elevated 5-fold for those people who had a stoppage after 91 to 400 days when compared to people who did not have a stoppage. And it was elevated 8-fold for those people who had a stoppage if opioids were stopped after being received for more than 400 days. The overdose deaths were elevated as well. I wrote the passage on the caution regarding retrospective data. You don't know the reasons for the stoppage or the pace at which it was done, but you cannot say that the veterans were safer after the opioids were stopped. So my general warning about conjecture from retrospective data: lots of conjecture from the Amy Bonnert study drove the widespread pressure to taper and stop as a signpost of making patients safe. I don't think the data is supporting that policy. The new data hint at undesired outcomes, but we should defer from aggressive conjecture from retrospective data. Let's be careful. The other issue that really arises here is that these patients have become a liability for their healthcare providers. A paper published last year showed that 40% of clinics in Michigan would not accept a patient on opioids. My own father called to get a new doctor. He's not on opioids in South Carolina. And after the insurance information, they said, "We need you to know our doctor never prescribes opioids." And he was like, "Oh, well, I'm not on them, but gosh, could I ever need them? Like, what happens if I get ill?" And then they said, "Well, we might, but that's a real concern for a practice." Finally, when you talk to adults about their care, and this is a qualitative study, it's concerning, and it echoes what I've heard from patients on social media and that I've observed. This is a study in the Gerontologist published last year. Purpose of sample: older adults had 3 or more chronic conditions and pain. 44% were on opioids at the time that they were interviewed. And they talked about erosion of the clinical relationship, abandonment experiences, feeling they had diminished power and voice in their care. They had ambivalence about opioids. They didn't all want them or ambivalent about them. They had a lack of access to alternatives to opioids, and they had fears that maybe when they got sicker, like my dad, maybe they wouldn't be able to get them because of the changes in the policy environment. This is by Christine Ritchie, a geriatric professor. So I'm going to close up by talking about what my recommendations are, and we can still take some questions. What's the right thing to do clinically? And then I'll talk about policy. The way I think about this is as a clinician, so I'm going to describe a defensible taper, and I'm going to describe an indefensible one. And perhaps you can then say, wow, you know, maybe I can sort my way through this. That's going to clean this up, although I've helped author one. This case is whole body swelling, you know, anasarca, and sedation from opioids and benzodiazepines, past heroin use, HIV, chronic pain, anxiety. Methadone was ongoing from an outpatient treatment program. I think this was in Boston at the time, and was on oxycodone from me and benzodiazepines from a psychiatrist who we didn't know existed until the psychiatrist passed away. And then suddenly we had a patient on benzos. And there was harm. The patient was falling asleep in the office, and this whole body swelling anasarca problem required extensive workup. And we came to the conclusion the methadone was the driver of the fluid retention. We had to taper medicines, both the benzos and the opioids, not entirely, but we got much of them. And it was really, really unpleasant. I actually described this in a TEDx talk from 2014 as a situation of helping somebody who I was not pleasing. But ultimately, the patient valued the care change and did feel better. So I'm not saying you can never do something which a patient hasn't agreed to. You just have to have an extremely strong reason and extremely careful safety plan, which we did. More common is what I call here a bad taper. And I do describe this on a podcast in case somebody wants to hear it. This is slightly altered to disguise the hospital, but it's a man in his late 50s or early 60s. I got to review the chart. Multiple medical problems, alcohol use and remission, pain of the back and other joints, on methadone, not as high a dose, and oxycodone for many years, and had been a kind of equilibrium. And there was a taper done by a clinical pharmacist and a physician based on the belief that safety would be improved. It's not that there was a problem visible other than the number. And the pharmacist's note in the chart was the patient expressed some concern but agreed to further reduction. But confusing matters was there was a simultaneous note written by a psychiatrist saying, I'm not sure I can survive this because of my pain. They're taking my medication away. Obviously, that's a bit confusing when two distinct providers are documenting things in different ways. Obviously, the patient could have said different things to different people. The outcome here is that a few weeks later, the patient was admitted to the hospital for intoxication sedation, having taken all of the last few pills, alcohol, diverted sedatives, and saying they were in despair over the opioid taper. The patient survived, but nearly died. This is a harmful taper. The reason for this taper was a number, not the patient's clinical condition. And the evidence that this act would have made the patient safer is not evidence that we have. So in turning to my last 2 slides on policy, I just want to comment that, 3 slides really, but in the past, we have regretted numeric targets that were adopted because they simply felt right to us. In diabetes care, there was a time where the HEDIS standard was to get every person below an A1C of 7%, and that was always good care. The evidence for that was weak when it was adopted. There's a paper here by Rod Hayward, but eventually that was changed because it turned out from trial data that we were harming some while helping others. In terms of how we do policy now, I think our policy should map to our clinical purposes. So I'll list 4 purposes and 4 policies. We want to care for patients with complex pain and rehab needs. So I suggest we fund continuing services for treating pain as a functional state, long-term continuing services, and not just as simple tissue pathology. There's psychology, there's mental health, there's functioning. It has to be enduring care. We don't want tapering due to institutional fiat because that seems to have the possibility of making the patient less safe. So we have to change the quality metrics, and we have to change the payer policies, and ultimately investigative thresholds that are being used right now if we want to protect that clinical objective. Clinically, we want to respond to overdose risk protectively. This will mean that we need to care for all of those risk factors I mentioned that include the prescription, but are beyond the prescription as well, and that likely requires multiple disciplines. Finally, we do want to retain relationships with patients who are abandoned or experiencing incredible fear for fear of abandonment. And that means we're going to have to de-amplify those pressures that turn patients into liabilities, and will require institutions, I would say, to measure who is lost from care. I can't tell you how many times I've heard from institutions that have reduced their number of patients at high dose, but cannot report where those patients are after they've made that reduction. That's the end of my planned remarks. I put up some references. If you're interested in a newer TEDx talk, which looks at opioids in particular, you can find it in Google. There's a couple of papers from the last few years